Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and this episode was recorded with the sponsorship and support of the Special Operations Medical Association. Thank you guys very much, and I hope you enjoyed the talk.
All right. So, there's a fancy disclaimer. And we'll start it off. So, yes, I take this topic very passionately. Back in 2005, I lost a very dear friend of mine due to some medical negligence from a medic that was operating down in RC South. She had received blast injuries below the knees on both legs, and no tourniquets were applied and no clothes were cut off to render aid. He felt that the male passenger required more help, who also expired due to blood loss, and it took her around 40 minutes. The flight medic that wound up picking him up out of Kandahar said that he barely had a pulse when he picked her up, and he couldn't believe that he had spent so much time on the male patient who had multiple trauma to the chest, broken ribs, pierced liver, and had left her there just to bleed out. And he was like, well, I didn't feel like it was appropriate for me to cut her clothes off because, you know, she's like a little sister to us. And I have been very furious about that ever since, because there's just no sense in her passing away. All she needed was a couple tourniquets. He could have cut her clothes up a little bit. He could have left some modesty, but at the end of the day, she's dead because of that. So, back in 2017, I was accepted into the SOMSA master's degree program, and this is part of my master's thesis that I wrote about, and I'm continuing forward, and others are also continuing these studies from USU and University of Minnesota and some other places. But at the end of the day, PCCC is the standard, globally accepted. A lot of our strategic partners are really adopting the policies that are coming out from technical combat casualty care. It has overwhelmingly been shown to be successful in numerous instances over the last 20 years that we've been fighting in G1. The demand from multiple countries to be TCCC qualified, whether it's through the National Association EMT or through deployed medicine websites, it's every month we're getting requests. At SOCSENT, we've had multiple requests from multiple countries. I've talked to folks from multiple SF groups and within civil affairs and PSYOP and everyone else that they want this training and they want to know what we have gone through and we take our lessons learned to adopt it into their first aid programs. The quotes here from the National Security Strategy. I am very passionate about the governments that fail to treat women equally do not allow their societies to reach their potential. That really goes after the soft truth, the first one. Humans are more important than hardware. We need to understand that women are increasing in numbers every year. As of right now, 22% of 18 to 24-year-old males in the United States are even eligible for the military. And it keeps decreasing. Back in 2018, it was 25%. Now it's 22, 23%. And it's continuing to decrease, and the women's recruitment numbers are up. In fact, just this year, they released the information back in March that an 18% jump in female recruits just in the Army alone. It skyrocketed almost 20% because they couldn't meet the quotas that they needed. So it brings us to limited in-depth research on combat-related deaths. Some of the comments that I received from members within COTC and members at the JTS years back was not enough females had died to really delve into this. So through the research, 173 females had died during GWOT out of 7,100 deaths. So when you look at the numbers, yes, it's a couple percent. But at the end of the day, as we continue to increase our female active duty and reserve and National Guard members, as we're dealing with more and more female casualties, we're working along with NGOs, what's going on in Ukraine, what's going on in Israel. You're running across more and more females. And if we are not understanding what the differences are, then you're going to continue to have a higher fatality rate. The Joint Trauma Registry showed that there was a 36% rate compared to the male counterparts at 17%. Dr. Haldeman, Johnston, and Rivera wrote 3 different papers from 2012 to 2015 on this. They continue to say we need more research into this topic, which is why when I wrote my paper, and now there's others that are continuing this good research, and they're finally quantifying what we thought was an issue. It's there. We know it is. They continue to do these training iterations. They're running these case studies. They're knowing that there's problems and that we do not have a firm grasp on being able to delineate how to treat a male and how to treat a female in combat. It's not written solidly into the doctrine. Some folks are better than others. Some folks are not. In that aspect, during GWAT, females made up an average of 12 to 13%. Now they're at 19. So on that differential, we had 173 deaths. We're rocking it. We had golden hour. But what happens when we have LISCO? And we've got tens and tens of thousands of females out there, but nobody to actually understand, hey, I need to do this, I need to do that step. These are the physiological differences that I need to be prepared for as I'm running through my triage. The photo here is of Lieutenant White. She's been working with the CSTs. After talking to one of the other CST females that was there with her when she passed away, the one comment that truly struck me was the fact that she was still in her uniform, and the only thing that had been taken off of her was her top. Her pants, her t-shirt, her boots were still on. And yet at that point, back in 10 years ago, trauma naked was still a standard for us. We cut all clothes off, we exposed the injuries, we know what the heck is going on with the patient, but they didn't want to do it. And the comment came out, well, I didn't want to expose her because, it'd be inappropriate, and I want to protect her modesty. Well, she passed away. So what were you protecting? At the end of the day, do you think she really cared about her modesty, or did she want to be treated properly and equally to a male? So with the higher percentage numbers, the truly interesting aspect when I really delved into this, I was able to talk to Colonel Shackelford and Colonel Burning, was that in the civilian sector, females have a 14% higher survivability rate as multi-system trauma patients versus their male counterparts. The National Trauma Data Bank clearly proves this year after year. Females will have a higher success rate when they're multi-system trauma patients and being treated out. So how could it be on the other flip side when we had the data coming out that was 36% flipped on the military side? So what is accounting for this disparity is 6 major considerations that I have. So you have your physiological differences. One of the main ones that I emphasized, which is near and dear to my heart, as my wife and daughters always put their cold feet on me at nighttime, is hypothermia considerations. So the case studies that are out there, females have a harder time compensating for hypothermia in the aspect of there is a correlation between muscle mass and your ability to generate heat. So in this, men are typically going to have more muscle mass. So when we're shivering, we're going to be able to heat up a little bit faster. Well, now I have a patient. If I have a man and a woman, and they're both injured in the same way, they've lost 500 milliliters of blood both. They're both continually shivering. They're starting a lethal triad. And I only have one space blanket, or I only want to have one HPMK. Who do I need to treat first? What are my considerations? Have I been trained how to think this through? Secondly is the orthopedic considerations. That was the main focus of the research coming out of Joint Trauma Registry and the Dr. Johnson and his colleagues, that the orthopedic injuries were extremely higher for the fatality rates. Are we considering what is going on when they have the pelvic fracture? Are we understanding that there are going to be certain differences? What if they have stress fractures originally and nobody could detect that, and then they start doing closed book, open book? Followed up by training verbiage. Follow the nipple line has been a wording and training that I've heard for 20 plus years now. When we're trying to do a needle decompression, follow the nipple line. Well, my point on that is, okay, not just females with breast tissue, but what about an obese male? If it's going up here, going off to the side, going over here, how are you going to follow this nipple line? And I still occasionally hear it. I know Kotze's come out and said that, no, you're not allowed to do that, but we still got some old timers that they're still teaching it. And even the younger guys, I've heard it in a class in the last couple of years, they're saying follow the nipple line. Okay, that's not going to be accurate. You need to make sure that when we're teaching these people, if you hear these things, okay, you can do that if it works 70% of the time, but what if you have an obese person? What if you have a female? Are you talking this through to make sure that they're thinking about it, rather than it's just in a rush, in an emergency, they're not thinking clearly and they just start stabbing away? Because do bad things happen when you just stab people randomly? Yes. Procedure landmarks, finding the Adam's apple. That is one that for hyperthyroid, it's something to consider. Again, it's verbiage. We're using it as a landmark. Even the mannequins that are out, the vast majority of them are still using a male neck. They don't have more subcutaneous fat, and they all have Adam's apples because they want you to be able to find it, and they want you to be able to do that right properly. Well, here's the problem. There's already research out there and case studies where they were in a hospital environment, had anesthesiologists doing hyperthyroid procedures on female and male patients. 29 out of 36 females were missed in a stable hospital environment, not in combat, not with all kinds of craziness going around, and they missed 11 out of the 36 males. I wish they had actually written further into the paper and talked about BMI, but they did not in the one case study that I was researching. I would venture to say that the majority of those 11 males that were missed were probably obese and had 35% BMI or higher, where it made it very difficult for them to find that Adam's apple. But it's another consideration to have as we're talking this through on what we're doing with our training. Dr. Shackford, she was very funny and caught me off guard with one of her comments regarding the training models and regarding how to properly treat females. She's like, okay, let's talk genital urinary injuries. Blast waves coming up from underneath a male, and you can just clamp off in the genital area. It's external normally. What are you going to do with a female? And I looked at her and I was like, what do you mean? He's like, well, think about it. How many men are going to feel comfortable taking that combat gauze and shoving it inside a female's genital area to stop a bleed? And I was like, I am very certain there's going to be a lot of men that are not going to want to do that and feel very awkward about this. But again, it's a consideration to have. How many of you or how many folks that you've dealt with that they've actually run that scenario on somebody just to throw them a curveball, just to see what they would do? And I would venture to say not many. For the reluctance to touch and undress the opposite sex, again, multiple case studies are out there. It was very interesting when I was writing my thesis. The American Heart Association and Red Cross both had just released their data from 2016 in stating that ever since 2014 and 2015, the amount of female deaths in a CPR situation, not even trauma, just CPR, had risen for the first time in over 60 years of them correlating the data above male survivability. So for the first time ever, females were dying at a higher rate than males. And when they went back and they started asking questions and they started to talk to the bystanders, like, well, why didn't you treat her? And they're like, well, I don't want to be charged with sexual harassment, or I feel very uncomfortable touching her breasts. I don't want people getting the wrong idea or putting my mouth on her mouth. And even today, as of 2024, they're still having problems with it. A couple of the solutions that they come up with was that they did realize that there was no female CPR mannequins on the market at the time. So that has slowly increased, and they're trying to do education on it. But again, it's a cultural consideration. People feel very uncomfortable. And when society is saying things, and you shouldn't do this and you shouldn't do that, it has negative consequences. Well, now we have that throughout the military. Like, we learn off of our civilian counterparts. The case studies that USHU is currently doing, they have 6 case studies currently going. One just finished up in Mexico that they were doing TCCC training, and it was definitive on the conclusion. The students were having a very hard time trying to cut the clothes off and trying to treat the female patients versus their male patients. The University of Minnesota has also got about 9 different case studies currently going on that it is the same. They are finding that it is very difficult. People are making excuses on why they do not want to remove clothing or why they are missing wound patterns. It's because they're feeling uncomfortable about it. They don't know what to do. They weren't trained because it wasn't in the curriculum to do certain aspects of trauma training when it comes to a female and how to get over the mental block of doing this. Medical errors with the opposite sex. There's various arguments back and forth. I know we had a discussion years back here at SOMA that giving blood to females or taking blood from females was considered a no-no because the pregnancy aspect. Later on, are they going to have complications when they're trying to get pregnant if you gave them a different kind of blood? At the end of the day, after talking with many smart people, Cap, Colonel Cap, very smart guy, numerous others, they said at the end of the day, what are they going to worry about? It kind of goes back to Lieutenant Walker, my old friend. Is she going to be concerned with having complications with having a child or being dead? Like, if they need the blood, give them the blood. We will worry about the other things later on. The VA can help them. There's numerous different organizations out there that can help you with IVF and help you take care of some of those considerations. But why would you deny them blood? Secondly, medical errors with the opposite sex for a number of years during GWAT, and they have gotten a lot better, but occasionally it's still happening, is the VA is issuing prosthetic limbs to the female patients that have lost, legs, arms, hands, but they're based off of male anatomy, so they're not connecting properly. And it is causing those individuals a little bit more angst as they're trying to get over what happened to them and psychologically process. And instead of having a smaller arm that would accommodate and look normal to their other arm, they had this larger arm that was based off of male patient. Again, it's just these little considerations that a lot of this was not looked into because we had so many fewer female service members in the military, and it wasn't well thought out. And then the cost aspect of it all is also another thing that has been looked at to rearrange and completely shift over to focusing on that has been not, let's see, what's the best way to say that? Not cost effective was what I was told a couple times. But at the end of the day, are we always going to be worried about cost effective or what's best for the person? It goes back to the soft truths. So for us, what do we want to do? Do we want to do our best for the person, or do we want to do what's cost effective? I state this with wrapping up with 2 stories. When the 11 Bravo females first entered the 82nd at Fort Bragg back in 2016, 2017, I had the privilege of having my neighbor was the first sergeant of that company. And he got to tell me a couple of the stories that happened that was just mind-boggling to me in how female medical treatment was so overwhelmingly foreign to them. They didn't know what to do in the situation, and it brought up some major UCMJ dilemmas as well as medical treatment dilemmas on the survivability of the female patient. So the first story was they were at Fort Polk in February. One of the females was in the water for a little too long. She comes out, uncontrollable shivering, couldn't mentate properly, couldn't answer the questions of the medic. What does the medic do? Male medic, by the way. He's like, oh, well, I need a core temp. I need to make sure it's not a seizure, it's not something else. Doctor says, repro temp. I need to do a core temp. He starts to pull her pants down. The platoon sergeant for that female was like, what the hell are you doing? And he's like, well, I gotta get a core temp. He's like, no, you can put that in her mouth. And he's like, no, I need to do a core temp. Like, this is procedure. Like, He's like, no, you're perfect. And he was like, I'm not a pervert. No, I'm trying to do the proper protocol. Like, this is, if it was a male patient, I'd be doing it to a male patient. And what wound up happening, he's like, you do this, I'm pressing sexual assault charges against you. Well, what did the medic do? Thought it through. He's like, nope, I'm right. He did it. Battalion surgeon, battalion PA, senior medic, had to go before the battalion commander, battalion sergeant major, and staff and defend the kid against sexual assault charges. Now fast forward 6 months. August, in Fort Bragg, out by the DZs. It is very humid, very hot for those of you that have had to ruck march way out there. So they're on a normal ruck march. One of the female space plants. She's overheated. They drag her off the road. They take her rucksack off. They take her top off. They start splashing water on her. They're fanning her. One of the guys reaches to loosen up her belt. She screams, "Don't rape me." Every squad mate throws his hands up, takes 10 steps back. Squad leader gets on the radio. I need a female at my location now. Takes about 15, 20 minutes. Female medic shows up. He's like, what's going on? They point at her, and she's like, what are you doing? Why aren't you helping her? No means no. I've been to sharp class. And she's looking at these guys like, she could die if she's got heat stroke. And he's like, not my problem. No means no. I'm not touching it. Now, I presented this dilemma to senior officers and GOs and sergeant majors, and I've asked them all the question. I was like, what would you do if she had died of heat stroke to that squad? I'd crush her last month. All of them would be out of the military. I'd court-martial. I'm like, really? So you have clearly defined that medical emergencies supersede what you're saying no means no in your shock and EO program. And they all give you that same look of, I was like, exactly. Medical emergencies are agnostic. Like, there's not gender considerations. When I talk to people in ER, they don't care. Clothes are coming off. They're doing treatment on a male equal to a female. It's the folks that don't have that background and that knowledge and have run through those drills a couple of times to break that mental break of treating a female. Prime example, when I got to work with the folks at Griffin Group many years ago, we would have to set up video cameras when we ran trauma lanes, and we had female actresses come out, and they'd be bawling and crying and saying, "Oh God, you're killing me, don't kill me." And it repeatedly happened to the point that we had to bring out video cameras and videotape these guys, because they would take the medic and throw it out of the way and then try and do treatment. And we would tell them at the end of this time, we were like, you do realize the female casualty over here had 2 minor injuries. Yes, she coughed up some blood. Yes, she was crying. The male patient over here had like 6 or 7 injuries that required multiple people to help him. But you literally threw your 18 Delta or your corpsman or your medic, you threw him out of the way to get in and take care of the female patient, all because she was crying. You're like, no, I didn't. And roll footage. And every single time it happened, and this is dozens of accounts of this happening, and once we got them to do it 2 times, we finally broke them. And they stopped focusing on the female aspect. The crying, the snot bubbles, all that, none of it mattered to them after they ran 2 full scenarios. And they were like, nope, triage, 1, 2, 3. And they went through the proper steps of how we're supposed to run a TCCC lane, how you're supposed to run march. It was no longer about saving the girl. It was about saving the service member that needed the most treatment. If I need to dedicate 2 or 3 persons to that, 2 or 3 people to that, great. I still got to pull security. I still need to do this. I still need somebody to man the radio, to call up, to get a burn in. They started following that, but we had multiple instances. 6 different people would be around the 1 female patient with minor injuries, and 1 or 2 people would be with serious casualties. Had to get through those mental breaks. Had to make them think it through and actually start to look at them not as men and women, but as patients. Who needs the help? Apologies. No, I did that. Back on. There we go. All right. So, gender integration. The executive order came out in 2016, so women will be participating in ground combat training. The DoD pushed forward with it. One of the aspects that did come out of this, especially with the special operations and SWIC, was the amount of stress fractures that were misdiagnosed initially. We wound up having, I think it was like 30 or 40 different females come through Camp McGraw when I was out there. And they were complaining of a certain amount of pain. And we're like, okay, yeah, shin splints, or the docs would look at certain aspects of it and they'd be like, yeah, it's normal. But then once they got through a certain portion, they just couldn't go any further. They went back, but they're getting radiology exams, and now they have like grade 3 stress fractures in their pelvis. And in two instances, I believe it was, they were told that you should probably never have a natural childbirth. Your pelvis is so unstable, and you've got so many stress fractures all over the place because of the amount of heavy lifting you've done. I know the Marines had mentioned that, and I think the Australians had said that in a conference a couple of years ago as well, that they noticed knees and pelvis were the two main aspects of the female trainees trying to step into the special operations realm, that they were having problems with this. With the memorandum that came out just in March, there are interesting aspects to the physical requirements. Yes, I know that ACFT is switching again. But I bring this up in the aspect of men and women can do all kinds of things. I've had females, they threw me on their back in full kit and ran with me 100 meters. I've had other females that couldn't put me in a skate-co litter and drag me 100 meters. It is what it is. Everybody's going to be a little different. I've had smaller guys on my team that couldn't really pick me up when I'm in full kit. I've had guys that could just throw me over one shoulder. At the end of the day, I want to make sure that when we're talking about making it equal, making it fair, yes. The one caveat with this one that I did notice when I was the senior enlisted at Fort Detrick, I had a couple of my female officers, they all had C-sections. Well, that leg tuck was pretty much impossible for them. Like, they practiced day after day after day and could not do it because the muscles had been cut in such a way. And it made it super difficult, let alone to get, the 15 to max it. Just to get one or two out of the way was really difficult. So again, when they ran these tests and they ran these studies, they were all testing it on 18 to 24 young females, most of them single with no kids. And so they didn't take into the considerations of the older women or any other women that had had a C-section or had childbirth. And to wrap things up, the current standard for trauma training in the DoD, tactical combat casualty care, everybody loves it. It's a great program. It still could take some tweaks. So I know USHU has those 6 case studies going on. The University of Minnesota, I highly recommend taking a look into those if you are interested in this topic. Contacting those individuals that are there, and I can get with anybody offline. But making sure that is linked into some of the new CPGs that we're looking at, how we're going to run trauma training. And then the female-specific physiological and sociological differences. Training, medical treatment, and policy. So the sharp EO policy changes, are we really going to get after this and make sure that people understand medical emergencies are gender neutral? Or are we going to keep telling people that no means no? And then the doctrine considerations for those other 19% and increasing. Thank you for your time.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast, out.